afternoon, everybody. If we can make a start. My name's Ruth Northway and I've got the privilege of chairing this afternoon's event. If I could just start with the usual business sort of things. No fire drills expected this afternoon, so if we do hear a drill, we have to leave the building. There's stairs just over the corridor on the other side, and also back at the entrance where you came in, and the assembly point is the hotel opposite. I don't know the name of the hotel, so hopefully not just some random hotel that you end up at. Also, if you haven't signed in, can I ask you to sign in just so that we've got a list of everybody who's attended? I'll send that one round. Okay, so in a moment I'll introduce our speaker for this afternoon, but first of all I just wanted to say a little bit about why we're here, to say a little bit about Adam. Not all of you will have known Adam. Some of you may have known him via his tweets. Unfortunately, I never got to meet him in person, which I regret, but learned a lot from his tweets. I was looking on the website yesterday and looking at his list of achievements, and I'll just give you a few. A winner of the Brit Writers Award, Gold Blue Peter badge, which I'm led to believe there aren't many around. He had a poem set to music, which reached #2 in the iTunes music chart for children. He was commissioned to write a poem on leadership for the NHS Confederation. Commissioned to write a rap to celebrate the launch of Disability Matters. He was commissioned by a national charity to write a lullaby to celebrate the birth of Prince George. And that's just a few. Now, I don't know about you, but I think most adults would be pretty proud of that as a CV. And what's remarkable is that Adam had achieved all of that before he sadly died from sepsis at the age of 15. What was even more remarkable was that he lived with cerebral palsy and quite complex health needs, and his communication was via blinking and via a spelling chart. So, fantastic achievements, but actually overcoming additional challenges to achieve those. And I think during his life he influenced many people, both people who came into contact with him directly, but also through his writing and through his blogs and his sort of tweets and things like that. And since his death, Paul and Zoe have obviously continued his work through setting up the foundation. And if you haven't had a look at the website for the foundation, I'd say have a look at it. There's some fantastic resources there. And also through having this yearly sort of ads chat to obviously to explore issues perhaps in more depth. What I will say is, if anybody wants to, there is a hashtag which I nicely wrote up on here with a pen that's not very effective, so you can't see it from the back. But basically it's hashtag AdsTalk24, so please do tweet, or I should be saying, I can't get used to saying X. Please X, no, please tweet. And then also I've been asked to say, and I have to ask my assistant here to hold a copy up, there is a book available. The book is available there. If anybody wants to purchase a copy, then see Zoe and you'll be able to purchase a copy. So without any further ado, I'm going to hand over to our speaker, who is Charlie Jones, who has come up from Bristol, where he is a clinical psychologist at Southmead Hospital. So I'm not going to say anything more because he probably will say more about himself as we go through. So I'll hand over to you, Charlie.
Ruth, thank you. Thank you. Hi, everyone. It's lovely to be here and to meet in person people who I've been in touch with through screens and through social media. So it's lovely to be here. And thanks, Zoe, for the invitation. And thanks, Ruth, for introducing me. And I think just to echo what Ruth said, I think just to reiterate that sense of remembering Adam and his life and his poetry and his contribution, and to feel that spirit of Adam with us today. I've got a few slides, I've got some notes. I'm just going to say a bit about where I'm coming from as kind of someone saying some sort of messages today. So I'm a clinical psychologist, as Ruth said, in an acute hospital. So Southmead is an acute hospital in Bristol, and I love working there. I've got some brilliant colleagues. I've worked in the NHS since 2004 when I started my clinical training. So this year it'll be 20 years. and I've only ever worked in the NHS. I've not worked anywhere else, unless Baker's Oven counts. And I love the NHS, but I think I might say some quite critical things in the next hour. A bit about what a clinical psychologist is, if people don't know, you'll know, Mike. But a clinical psychologist does a psychology degree, so 3 years or 4 year undergraduate degree, and then typically a number of years of experience as an assistant psychologist in the NHS, or it could be working in a prison, it could be working in a care home or as a support worker, but some years of clinical experience. And then it's a 3 year doctorate to be a clinical psychologist. So most clinical psychologists, when they newly qualify, are at late 20s, often older, but it's a long road to be a clinical psychologist. And you find psychologists in all kinds of different places in the NHS, so a lot in mental health. I started out in older people's mental health, so in those days it was anyone over 65 was classed as older people. So I did that for 9 years in South Wales. So there was a lot of working with people affected by loneliness and social isolation, cognitive impairment and dementia. And then I worked a couple of years in staff wellbeing. So that was really interesting because that was at the time of the Francis Report, 2013. And in Wales, they were already thinking about staff wellbeing, so the wellbeing of the workforce. And that, at the time of the Francis Report, that was really relevant and fascinating to be working in that area. And then for the last 6 years, I've been working in medicine in South Mid. So my day-to-day clinical work is working with people with diabetes, people with Crohn's colitis, asthma, HIV, people who've had heart attacks. And it's brilliant being a psychologist in an acute hospital. So you've got your clinical work, and then you've also got this sense of how's the hospital feeling, what's happening in the hospital. And wherever psychologists are working, like whatever the context, we're working with distress, we're working with psychological distress. And whereas I suppose a medical model might be, how can we sort out this distress, how can we get rid of the distress? A psychological model is more, how can we sit with this distress? How can we understand it, make sense of it, what might help? And over my years as a psychologist so far, I think what's been interesting is the skills that we use in our clinical work with individual people. So things like listening skills, empathy, thinking about multiple perspectives, ambiguity, thinking about meanings and feelings. These skills we use at an individual level, I think increasingly we see you can use those same skills at the level of the team, the level of organisation, the same skills applied at different levels. And I have this kind of sense of it, it's a bit paradoxical because we spend all these years training, all this experience, do the doctorate, and then essentially what we're skilled at is we kind of sit and listen and try and be present. And I think especially in an acute hospital environment, I'm really aware of the consultants and all the nurses and allied health professionals doing all this really clever stuff and all the tech and the scanners and the drugs and the cutting edge stuff. And what we do in clinical psychology is relatively simple and basically human within that environment. So what I'm wanting to do today is to bring my experience as a psychologist to these questions. So essentially around harm in healthcare, what is going on with that. And in preparation for today, I've spoken to a number of people, some of who are here, and I've listened to other people's thoughts. So I'm used to working in units of an hour, but usually in an hour I would speak for maybe 8 minutes and I would listen for about 50 minutes. So the idea of speaking for an hour is not something I'd normally do. So I thought, in terms of how do I prepare, I need to get the listening in somewhere. So I've met with various people and tried to hear other people's perspectives. And essentially what I did was I just sent people these questions and then just asked people on a Zoom call, what do you think? So here's the people I've spoken to, and you might recognise some of the names and some you might not. It wasn't a scientific process particularly. These are people who are in my networks and just people who I thought would have a response to this kind of area around harm in healthcare. And I'm very grateful to these people. So we have doctors up here, there are a surgeon, there are nursing colleagues, academics, kind of consultants in leadership and management in the health service, people very experienced in the health service. There are people who are, I suppose, activists in health and social care. I think crucially up there are people who, so Joanne, Susanna, Caroline, Deb, there are people who have direct experience of harm in healthcare, and I think it was very important for me to speak to all of these people, but I think a real impact on me has been the reality of what's at stake here. We use a word like devastated very lightly these days. Your football team was lost. You really get a sense of the devastation of harm in healthcare and the impact on people's lives. So I think much as I might go on to speak in quite abstract general terms, I think it's really important to hold in our minds the lived reality for people whose lives are affected by harm in healthcare. The humanity of it, the grief and the loss. I think also as we go through, if we hold in our minds, what would Adam be thinking today? What would he be writing? So generally what we're talking about for the next while is an event has happened, harm has happened, and building up to that event, healthcare professionals might have noticed things, might have spotted things and not said anything. Or maybe families, patients, people did say things and weren't listened to. Then harm happens, and then afterwards we all know this, afterwards we get this kind of fork in the road of either do we go down a path of transparency, honesty, openness, apology, let's try and understand what happened here, or do we go down the path of covering up, closing ranks, making life really difficult for people. And in my conversations with some of these people, I've come across this term compounded harm, which I've not heard of before, but essentially as if the harm of what happened wasn't painful enough, you get this added layer of harm by the investigative processes which are so kind of lacking in humanity, lacking in transparency. So compounded harm is a real kind of learning for me through this process. So the questions to hold in mind as we kind of go into an inquiry are, why do failings keep happening? Why don't we learn? And how can we do things differently? And over the last few months, ever since Zoe asked me to come along and thinking about this, I think my thoughts have unfolded and meandered, and every time I've spoken to someone, my thoughts have moved on. And I think for this talk, I do have things I want to say, which I've written down, but I don't want to just go through some kind of neat and tidy PowerPoint slide with a kind of sense of certainty. And my sense of working with people is things are not neat and tidy. What matters is having space to kind of think together, to connect with people, to connect with ideas, and I hope we can do some of that. So I think listen to what I'm saying and see what lands and see what resonates. Kind of let your thoughts drift a little bit. And I'm not going to do like an academic type talk. It's just going to be some thoughts and see what connects. I've always been interested, since those early days of working with older people, I've always been interested in how is it that good people, just people, how is it that people end up doing bad things or unthinking things? And then how is it, having done something bad or unthinking, how is it that these people cover that up or try to hide it? And in those early days working with older people, I thought a lot about elder abuse in care homes. And my experience was that you'd be aware of this really oppressive, stifling system, and then you'd meet individual carers, individual care home managers, really lovely people, really decent public servant people. So you'd have this sense of person within the system. I've always been interested in this. And just as an aside, I have two sons, Freddie and Noah, who are 9. And they have additional needs, and they're not in mainstream school. And we have to engage with the local authority around their education, health and care plan, EHCP. It's their mum who does the vast majority of that. And we're very aware in that situation of how, when you deal with individual people, you really can think, gosh, I trust this person's decent, obviously working on a stretch service, but thank you for helping. But the experience of the general system is awful, is really frustrating, it feels really inhuman. So I'm here as clinical psychologist, I'm here as a dad as well. So how I work as a psychologist is, bear in mind all the years of training, it kind of comes down to something quite simple in the end. How I work as a psychologist is something like this. So let's describe what's happening. Description. Then, how can we find out what's kind of underneath that? How can we get a sense of understanding what's happening and what might help? And this is overlapping. I don't know if it's familiar with some people who might know about adaptive learning. It's kind of overlapping with that. But essentially, and it's not a linear process. I mean, I think it's not a sequential thing, but essentially there's something about starting where you are, describing what's going on, trying to understand it, and then what might help. So I'm going to structure this talk based on these 3 parts. And this is about being present, about sensing, about kind of trying to see what's going on. So I'll start here. I'll start with a description of what's happening. And I'm going to start with a sense of the system, what we all call the system. And I've got a slide which has these 5 things on which I'm going to go through in turn. So my starting point, so what I see as a psychological way of working, let's describe what it is. I'm going to start with this idea of a machine model. So what do I mean by a machine model? I think this might be familiar to a lot of people, but my sense of working in the NHS, and I think people I speak to, is that our work is tasks. So a good job is to get through your tasks. Healthcare is controlled and standardised, like a factory with conveyor belts and processes like that. And so there's a process for everything. It's very complicated and there's very little space to think. So, and you get entrenched patterns of behaviour which are driven by compliance with standards and procedures. Meetings, of which there's a lot. Meetings are framed as decision-making spaces, updates. Meetings are not typically for reflection or creative thinking. And you see the power of the machine in the language that we use. So we'll talk about efficiency and compliance and productivity, cutting out waste, command and control, certainty, levers for change we talk about. And any attempts to soften the machine or challenge get kind of mangled through the machine. So, you know, someone might talk about kindness in healthcare. How do we operationalise that? Would be the next question. So even attempts to soften the machine get fed through the machine and get turned into the machine language. And we use neat diagrams, pyramids, and concentric circles and hexagons all the time to show control, to show predictability, to show linear causation. It's all part of this machine. And I think at an experiential level, I think there can be a sense of guilt at taking any time out to catch up with a colleague, to try and engage with some reflective practice. And not because there isn't a will to do that, but very often we can book things in like that and we cancel at the last minute because there will always be something more urgent, and there's a real sense of urgency. Second thing, fear. It's fear through the system. Constant sense of scarcity. There's never enough. That's the feeling. There's never enough, and so you're kind of competing with colleagues in different teams for scarce resources, and that sets up a certain energy. And what fear does is it narrows thinking. It narrows our thinking, and over time that leads to a kind of blunting of professional curiosity, a blunting of autonomy. People turn up and do their tasks, and we're not particularly good at questioning things. So fear also in terms of, will I be supported if something goes wrong? Does someone have my back? So I think there's this constant base level of anxiety that's just there. And I think it's realistic that we cut corners all the time. I cut corners all the time. And yet you know the environment prizes compliance. And yet you could never be compliant with all the things that you have to do. So you've got this constant sense of, am I going to get away with it? Am I going to get found out? And many nights you go home and think of the things that you haven't got around to doing that day, and you just hope it will be okay, and mostly it is. But you know, I experienced that. This must be happening. Thousands and thousands of people experiencing this, I imagine. Reputation management. When speaking to those 20 odd people I showed at the beginning, this came up over and over again around reputation management as such a driver of activity. And I think we see countless examples of this in the public domain. And over 10 years ago now, a quote from the Francis report was, there lurks within the system an institutional instinct which, under pressure, will prefer concealment, formulaic responses and avoidance of public criticism, an institutional culture which ascribes more weight to positive information about the service than to information capable of implying cause for concern. That was in the Francis report 2013. But yeah, a strong theme of reputation management came up in conversations with people. This idea of, there's a veneer of doing the right thing. We talk about compassionate leadership. Underneath that surface level, there is business as usual, which is largely the machine model. And we think of the huge efforts that go into CQC visits, to prepare for the CQC coming, to demonstrate that we're doing really well, and that's driven by our outward-facing reputation. Effort goes into discrediting anything that would go against our reputation. And in speaking to people who've been directly affected by harm in healthcare, it is this sense of the compounded harm that hurts so much, the denial, the closing of ranks, the impossibility of having a human conversation. So reputation management is a real biggie. So the machine, the fear, the reputation management, this drives culture. And I was chatting to Ruth before, and we were talking a bit about this, weren't we? We've been talking about culture for forever, and round it goes. My sense of this is, I see it most with, I think, like newly qualified people or people coming new to a system where you can see this arrival of people with intrinsic motivation, intrinsic wish to care, to be ethically led, to be thoughtful. People don't typically come into healthcare for the money. There's this sense of wanting to help. And I think what happens is there's this transition to extrinsic motivation through targets and compliance, and I think we potentially lose touch a bit with our inner ethics and our inner motivations. We rely so much on policies and protocols, we end up not trusting ourselves, not trusting each other. We're always needing to provide assurance. I think if we think back to the emphasis on tasks in the machine and reputation management, we can get this disconnect between what the organisation needs to do, which is get more work done, and what clinicians want to do, which is to do a good job. And we get a very tricky situation here where the narratives in organisations are, we want to be kind and compassionate and person-centred, in line with reputation. And I think, of course, that can be genuinely intended, but then we get the kind of frontline experiences. This just isn't possible to do that. It isn't possible to deliver care in that way because demand is too high. And I think from a staff experience point of view, it can breed cynicism, and it can feel a bit like gaslighting. This sense of there's this outward message of we're aiming to be compassionate and offer excellent care, and but our experience is the difficulty of doing that. And we might ask, who gets promoted, who is successful in this system, who gets the successful business cases, and there's this sense of if you're good at playing the game, that's in your interests. Can we make it look pretty? Questioning the narrative is not encouraged. Now, I appreciate these are strong views, and of course there are loads and loads of people out there who are trying to challenge this and who are trying to shift this, but I think it is important to recognise that this narrative is out there around what it takes to survive in this mechanical system. And I want to talk about a specific paper which I hadn't come across until preparing for this. It's written by a psychotherapist called Farhad Dalal, and it's one of those papers where it blew my mind reading this paper. It's a critique of managerialism, and it was one of those papers where when you highlight sections and you end up the whole thing is yellow because you just highlighted everything. It's a critique of managerialism, and this guy Farhad Dalal is saying scores and measures make sense in mechanistic settings like factories, but when you apply these to people, they become really problematic. It's objectifying and it's dehumanizing, and it does away with the human capacity to think, and it's the capacity to think that makes us ethical. There's this idea that we can predetermine outcomes by writing policy, that human interaction is measurable, and if we follow procedures properly, they'll produce predictable outcomes. This is reducing people to things. It's objectifying and dehumanizing. And I do want to say, the people I know who work in management roles are excellent, caring, warm people, and who I appreciate a lot. And I think this description of managerialism is a core part of the culture that we work in, and I think both things can be true. This idea of good people in kind of blunting systems. Once policies and procedures are in place, managerialism decrees that it's our professional duty to follow them. Right and wrong becomes equated with compliance, with rule following, but without thought there can be no ethics. And this sets up a conflict in staff because, and I think this is core to our culture, in contexts of fear and steep hierarchies, when you're caught between doing the right thing and doing what you're being asked to do, we're prone to doing what we're asked to do. And this is the kind of undergrad psychology, Milgram experiments from the 1960s. You know, it's particularly the case when paying your mortgage depends on it. So this sets up a tension in people, and this tension goes by the name of stress. And then because we have this kind of machine approach, we might think, what's the cause of stress? What's the solution? It's to de-stress. So in this paper by Dalal, he says, you know, we might set up tranquility rooms. You can think of the equivalent. Tranquility rooms in which people can de-stress. Leaders can announce that supporting the mental health of our workers is a key part of being a compassionate employer. However, no reference is made to the inherent tensions of day-to-day working, this being the real reason for the stress. So that was a description of culture around this kind of what is. And the last part I want to say around this, in this first part around a description, is something about psychological defences. And I see this, you know, in one-to-one work with people, but also in teams, and I see it, you know, in healthcare as a, you know, a conceptual level. So, and going back 70 years, there's a psychiatrist called Isabel Menzies-Liff who did some really brilliant work in hospitals with nursing. And it's 70 years ago, but it still holds very true. And we might ask, well, how has 70 years gone by and we still are in a similar place? But what she wrote about was how protocols and procedures are part of the design. They're part of the design in hospitals, in healthcare settings, to defend us from the painful realities of getting close to someone who is sick. So in other words, the environment is designed to defend against feelings that would otherwise overwhelm us. So the defences are there to help us cope, which are essential for emotional survival, but crucially, they work against human connection. And they also prevent healthcare people from learning to cope with these inevitable stresses. Everything's controlled and regulated. There's a denial and detachment from feelings, and kind of decision making and thinking is replaced by following protocols and procedures. But remember, without thinking, there can't be ethics. And these practices and procedures, they might have emerged as good quality or professional conduct. And practices that would have felt normal, that would have felt clear, when in fact they're working to defend healthcare professionals while simultaneously undermining care. And what it means is that good, caring people are capable of creating mindless services that work poorly and fail the people that use them. Also within psychological defences, I think there's something about professionalism. Professionalism reduces people to a kind of narrow version of ourselves. There's a kind of switching off of parts of our humanity to function. And I think professional can be seen as a bit cool and a bit detached, not emotionally involved. And we use this kind of third person way of talking when we're being professional. I think we value being drilled in certain ways of thinking, compliance with processes, productivity, anything that interferes with that, like being emotionally connected to a person, a patient, essentially gets in the way of being able to work productively. And so can be seen as less professional. So we create this illusion to ourselves and to others that we're doing a good job because the forms are being filled in and the procedures are being followed. Meanwhile, the system becomes immune to the sight and sound of pain, and it all becomes a bit uncaring. And all of this about psychological defence is all typically not talked about. It just hangs there in the atmosphere. So what is patient safety in this kind of context? Will patient safety be achieved by the machine? by getting the policies right, by people following procedures properly. With each failing we have, procedures get tweaked a little bit. There might be a new action plan. People in authority want to be seen to be acting decisively. But surely more regulation just increases the bureaucratic burden that's already swamping public services. Every new regulation that's introduced, we're told, this is the one that's needed, this is the one that will make us safe. To an extent, are we all invited to just suspend our disbelief, to collude in a script, in a performance of safety? How real is it? What is? This is a description of what is. Move on to how can we understand what is? How can we get underneath that? Go deeper under the surface. I'm going to bring in some of Adam's writing now. Because if we've been talking about the machine as a model, what is actual reality? The kind of complexity of reality, the organic kind of richness and humanity. Adam wrote something that I think is really relevant here, which I'm going to read out. And it's called Layers of the Rainforest. Community climbing in the sky, creatures clamouring and calling, the canopy covers like a cloak. Trees reach tall, touching together, entwining treasure within branches and twigs. Underneath is the understory, unlit and unseen. The rainforest holds the unknown. The forest floor, a fabric of foliage, fragrant flowers and fascinating frogs. It may be far away from Scotland, but it affects us all. The rainforest is full of the future. So I hear Adam there talking about the forest floor, what's there, that rich, organic, kind of, you can feel it's like sensory. And I'm also going to read another one out, because, and you'll all know this one, this is about what's happening behind the scenes. Who's kind of, let's not just take what's on the surface, let's go deeper. So it's not Christmas, but this is Christmas gibbons. The gibbons are fun at Christmas. They don't mind the snow. Gibbons are fun at Christmas, but there's something about them you don't know. They are Santa's secret weapon. They work on Christmas night, swinging across the rooftops. They really are a sight. Bringing lots of presents, all around the world they go, more agile than the reindeers, swinging to and fro. They're Santa's secret posties, bringing gifts wrapped in paper and ribbons. You thought the reindeers did this job, now you know it's the gibbons. So in both those poems, my sense is Adam's talking about something behind the scenes, something that we don't maybe see straight away. And I wondered, looking through Adam's words, I wondered if he might have gone on to train to be a clinical psychologist. And the idea of playing with words and meaning I think it's absolutely core to what we do in psychology. So the complexity of actually what's happening, the kind of reality, that kind of earthy humanity. And I think the capacity to acknowledge what's here, to be really present, is actually extraordinarily difficult. The anxiety of that, all the things that pull us away from being present. And yet one of our key aspects working in clinical psychology is making space to listen, for a person to find out what it is that they need to say. It unfolds. And sometimes a stuckness can be relieved when something hidden becomes more visible. So something that was unconscious becomes more conscious. So I'm going to talk about hidden tensions, because I think this is really important. And this can be with individuals, it can be within organisations. We're actually negotiating these all the time. And I suppose my point is it's liberating to become aware that these tensions are there. Without awareness of these tensions, we can end up working against ourselves, or experiencing a kind of self-defeat. I don't know if anything's going through your mind as you hear that. Essentially, we can be going around in circles, and without realising why, and it can be the basis of all kinds of psychological problems. So at an individual level, examples might be, I really want to make a difference in the world, but I just want a simple life. I want to be present with my kids because I know that's really important, but they're doing my head in and I really need some time to myself. I don't want to get caught up in the capitalist machine, but I do worry about having enough money for the future. I really want to look after my diabetes health, but I just want to be free and live a normal life. So it's important to identify these and be able to say them out loud. When you can name and identify attention and it's more conscious, you're then in a better position to decide what to do next. It doesn't make the tension go away necessarily, but you're more conscious. You can just more consciously take a next step. So it might not be a case of resolving tensions, it might be a case of coming to a both and, where two things can be relevant at the same time. And this is another key part of working in clinical psychology, is the both and. But there are these tensions. This is the reality. There are tensions, and it's not because anything's gone wrong or anything's failed or because we haven't had the right training. But the point is, you can't max out on everything at the same time. If you want to be more compassionate, you can't be as productive. We have to be able to say this. And I just wrote some, across healthcare, I wrote down some tensions that I see. So on the one hand, the need for productivity. Loads of people are waiting right now for knee replacements, hip replacements, all kinds of chronic pain appointments. People are waiting in pain, lives on hold. So absolutely there's a need for productivity, and there's a need for quality and safety, and for staff to be well and to create enabling conditions. On the one hand, we need guidelines and protocols to make sure there's some sense of minimum standard. But we also need people to be free to think and to give compassionate care and work ethically. We need policy on the one hand, but on the other hand, we need just basic kindness on a human level. We might think, how are they in attention with each other? There's a brilliant paper by Julia Unwin that people might know from Carnegie, UK. The paper was called Kindness, Emotions and Relationships, the Blind Spot in Public Policy. I wrote down a quote from it, it's so good. This is about tension between policy and kindness. So a GP receptionist has known the family of the patient well. She knows that if they're asking for a home visit, they'll not be doing so without a good cause. So she encourages the GP to pop in on her way home. The neighbours see this and are outraged that their calls to the local surgery do not merit the same discretionary help. They raise it with the practice committee and on social media, and the receptionist is reprimanded. A binding protocol is created to make sure this doesn't happen again. So even at a very basic level, we all say this about, let's be kind, we need to be kind. But it's not as straightforward as that. Even kindness can be in tension with other things. We say we want collaboration across the system. Of course, and there are finite resources and services are competing, so these things are in tension. One from Amy Edmondson's book about hidden tensions, I don't know if people have come across this, Right Kind of Wrong, which is a book all about failing well, the importance of that. She says, on the one hand, we want to do well for people, we want to get things right. On the other hand, we want creativity and innovation, and part of that is learning from failures. So Amy Edmondson says, describe the bind out loud, name the tension, bring it out into the open. So I think hidden tensions, whether it's working individually with a person or within services, there are tensions. And there's something important about making these visible so we can talk about them. So if you imagine a scenario, perhaps fairly recently in the NHS, huge backlog, huge waiting list, and we have a tension between productivity and well-being, staff well-being, for example. So as we face huge waiting lists, a brave CEO might say, we have a need to be as productive as possible. But we recognise that in emphasising this, it could compromise how compassionate our care is, and it could compromise the well-being of our staff. How do we move forward with this? Recognising the tension. But instead what happens is reputation management comes in. And what we say is, we're going to be really productive and we're going to give exceptional care and exceptional compassionate care. And what we do when we say things like that is it hides the reality, and then that means we can't talk about it. So that's where reputation management is such a bind. So in my fantasy, if we imagine an organisation where tensions were talked about more honestly and openly, there might be people within the organisation who are good at highlighting where the balance isn't quite right. They might give feedback, they might notice things. These people should be seen as system leaders and really useful. For example, if we notice that people are really flagging in a particular area, we might need to dial back on productivity. The idea of feedback loops and then responding meaningfully to feedback. So if we try to increase productivity and we've described the risks attached to that, if something then goes wrong, we can say, aha, this might be one of the times when we've put our foot on the accelerator too much. And that doesn't make everything okay, but this is a different starting point from saying, everything's fine, everything's safe. So I think a wise perspective, it's wise to be able to hold and see these tensions. A wise perspective is one where we can see the framing through which we're thinking. So having said all that about the machinery of healthcare, of course, we need to see ourselves as individuals, we need to operationalise things, we need to get stuff done, we need to get tasks done. But we also need to see that we're interconnected, we need to value our relationships, that we're working in a social and political context. So yes, we need the tasks, but we also need to recognise the conditions that we're working. These things are in tension, and the problem is things are very much weighted more towards the mission. The next part of understanding what's happening, understanding it, is that it's hard to grow relationships. So obviously, health systems are not just about rules and procedures, they're about people and relationships. We have talked for decades about person-centred care. We all know person-centred care is an invitation to get closer to the lived reality of people, to be in relationship, which is where healing and where care happens, but it feels continually elusive. It would be a brave trust to say we have nailed person-centred care. Why is this? It is not a deficit of knowledge and skills. It is not because we're unaware. It's not because we haven't been trained. Why person-centred care hasn't become more widespread is because it's a more psychologically painful and anxiety-provoking place to be. If you get closer to someone's experience, it's more anxiety-provoking. So in order to if we're really serious about person-centred care, it needs an infrastructure around it. Things like clinical supervision, reflective practice, these things are always overlooked, always the bits that are missing. It is very difficult to nourish the relational side when the machine is so dominant. Clinical appointments are very stretched. It's very difficult to get continuity of care. And between colleagues, I've had consultant colleagues come to me and say, there used to be just informal ways of catching up with colleagues. There was the doctor's mess, we could have lunch together, we could have a cup of tea together, and in that cup of tea it might be, how's things at home, and I had a really difficult consultation this morning, and there'd just be informal ways of catching up and nourishing relationships. Over the years, that's eroded. It's been eroded away, and we now try to offer more formalised psychological interventions, which is not a replacement for that informal relationship kind of structure. It's in relationships that we can explore uncertainty, not knowing. is in relationships where we can share feelings, which are an important part of reality. Somehow not knowing brings more of a person into a room. Our relationships are deepened by sharing our not knowing, our uncertainties. And coming back to Menzies' list, these emotions are intrinsic to healthcare. They are there whether we like it or not. Natural to think, this patient's making me really angry, or I've been avoiding this conversation all day. Doesn't make you a bad person for thinking these things, but it can be uncomfortable because it can conflict with your sense of being a caring person. It's why things like Schwartz rounds and clinical supervision reflective practice are so important. So again, make these things conscious so we can talk about them. And our relationships can be containers for these difficult things. Going to this. So do we avoid this? Do we avoid this idea that healthcare is harmful? Instead, we talk about patient safety. So this was another key theme along with reputation management. This idea of we need to talk about healthcare as harmful. This came up loads and loads of times in conversations with people. So to talk more openly about harm rather than just talking about safety. How can we make this more conscious, make it more visible? The point is we deal with harm. If you're conscious of it, less of it happens. But because we focus on safety, obviously we do that for the right reasons, this can turn into seeking assurance, it can seek into seeking perfection, and we can claim to be safe because the metrics say so. But for anywhere to claim safety is really problematic, because safety is created moment to moment in a complex reality. So I'm proposing we need to shift from seeking safety to becoming more aware of harm. And I wonder if intuitively we have quite a good sense of harm. Yeah, our natural instincts, we've almost got antennae for harm, but these natural instincts can get overwhelmed by our mechanical ways of working. And we've almost started to become a bit robotic, and our instinctive antennae, if you like, are less sensitive. So there's something about becoming more conscious and more bringing it from the kind of the hidden to the visible around harm in healthcare. How much truth do any of us want to talk about? How much do we want to bring into our conversations? I think this is a slightly more contentious area. I don't know if this might bring up some thoughts or some sharing. I think this needs some careful thinking. So in more paternalistic healthcare, I think there can still be this tendency to not want to tell patients the full truth because it might frighten people, it might worry people. And yet actually isn't the better thing to say to have more transparency, but say about how we can mitigate risks. So we can explain things more fully, but we can do something about that. So definitely there's momentum for more truth-telling, to explain what's happening, to explain about risks. So you're left with this sense of, as a patient, that there is risk, but it's as low as is reasonably practicable. And be honest about this. And I had some fascinating conversations about fall prevention in Wales, which I'll just share about that. So there's a lot of context to this, history to it, but there was a lot of work around falls prevention, understandably. It's such a difficult situation, falls. But a response to preventing falls could be, well, we need to keep people in bed. But then clearly being immobile is really bad for people too. So the uncomfortable truth is we can't keep everybody safe, especially when they're very limited staff. What we need with falls is a conversation with a person, perhaps with a family, and there's a balance to strike between preventing a fall and the problems of being immobile. Let's have a conversation together about how we manage this. So be conscious of what's going on and what the risks are. So, why is it contentious potentially? As a potential counter-argument to truth-telling is, what about situations of great vulnerability? Is there an argument for some caution here? Is there a hidden tension? Do we on some level need a reassurance of safety, as well as needing honest conversations about harm? So when we're vulnerable, maybe we want to see nurses and doctors as superhuman and heroic and all-knowing. That basic sense of you're in safe hands. I had a fascinating conversation about a research project that was going on, a big research project, and it involved the research team going around patients in a hospital setting, inviting people to talk about their thoughts on risk. Nobody wanted to talk to the research team. So the findings weren't about what people said, it was the fact that people didn't want to engage with that, and that there was this sense of, when you're in that position, when you're in a hospital bed, you don't want to talk about the risks that there are. So that was interesting. But to not be informed of things, I came across this term which I hadn't come across before, epistemic injustice. You know, when a hospital team, doctors, nurses know something about you that you don't know yourself. And I think there's something here around power and the nature of collaboration between healthcare professionals and patients, people. What is the nature of that relationship? And I think this is where it's in the how, isn't it? Because clearly there's ways of having a conversation. And my view is I'm very much with more truth-telling. I think that's really important. But surely that needs to be embedded within a relational context. And I think we have to ask, do we have an environment for that? Last part of this section, which was a learning for me, was different forms of justice. I don't know if this will be familiar to people, but it wasn't to me. But something else to raise in our consciousness is, what do we mean by justice? You know, after an incident has happened, after harm has happened, there is a need for justice. But there are at least 3 kinds of justice, and it's important to understand what these are and that these might be in tension with each other. So there is justice in the form of retributive justice, so penalties. An offender needs to pay a penalty. We might think of a word like perpetrator. There needs to be something retributive, corrective. The second form of justice might be something like system learning, and this might be more of the no blame kind of approach, where we're thinking about system learning. And the third form of justice is some kind of repair, some kind of repair to the damage that's done to people affected by harm, including damage to trust and relationships. So these different forms of justice might be in tension with each other, and it's important to raise that in our consciousnesses and name that so we can talk about that. So we've had a description, there were 5 things on that side. Now we have understanding what's happening according to these things. Now, what might help? So, main thing is about growing a relationship, something about collaboration and alongside-edness, which I want to talk about. I'm going to read another of Adam's poems, because he's written one which I think is all about working together and collaboration. And it's called The Green Fish. So, the green fish wakes me up in the lake. He swims with me through the water. The green heron glides speedily to the bank. I dive into the beautiful depths. The heron plummets under the water to join me. The fish plunges down to join us both. We swim together through the calming and peaceful waters. The green fish and the green heron sparkle, 3 amphibious allies dancing in the depths. I think that is beautiful. I think it's a beautiful poem. I think that's about being together, bringing together difference, and something beautiful happens. So how can we move towards more honest and open relationships between healthcare professionals and patients, people? Where there's more listening, there's more dialogue, more alongside-edness, where patients are more involved in their own care, where we can think and listen together in the moment, in a relationship where we can acknowledge that there's potential for harm and we can name that and talk about that, where there's a sense of unfolding sharing as more information becomes available and we have an ongoing sense of informed consent. Fundamentally, we can only support safety by acknowledging that harm can happen. General sense of patience, people need to know, otherwise we get this epistemic injustice. But also bear in mind that as a patient, as a person using care, it could be quite confronting to be told that harm can happen. So the messaging needs to be with care and it needs to be in a relational context. I think historically in more paternalistic healthcare, where the doctor knows best, it would have been a judgment call from the doctor, how much information to share. But how can this be more of negotiation, and what conditions does that need? So an example, I suppose, a sense of shared ownership of risk and uncertainty, where there's a degree of responsibility on both sides. A doctor might rehearse his or her clinical reasoning with a patient, with a family, acknowledging that there's a degree of uncertainty. The person might then respond to this with their own reasoning based on their life context. There's a shared understanding, appreciating our common humanity while respecting our differences, different roles. So alongside-edness, honest conversations. What would enable this? What are enabling conditions? I think meaningful staff well-being is really important, and I think the core of that to me is a sense of community. So a sense of, throughout the system, knowing someone's there for me, someone's got my back, it's okay to make mistakes. People feel safe to speak up. If there's a sense of community and things start to crack, either within colleagues or within myself, I've got a sense of I can do something about that, I can speak to someone. So I think meaningful staff wellbeing in the form of networks, relationships, community would be an enabling condition. I think disrupting those entrenched habits is important. I think if we doubled our resources overnight, it's not going to happen, but if we did do that, I don't think we'd suddenly think, aha, we finally got capacity, we can do all those reflective practice sessions we've always dreamed of. Because we're stuck in habits. We're stuck in habits of firefighting, reactivity, rescuing. So how can we disrupt those patterns? Things like Schwartz rounds, clinical supervision, reflective practice, something I've been involved in, spaces for listening, small interventions that can disrupt the habits, these entrenched habits that are there. How can we disrupt what it means to be professional? So that professional is all about openness and listening and humility, and it's unprofessional to get into all those defensive practices we talked about. How can we find ways to be real with each other, to stay in touch with who we are, and be professionals willing to work with feelings? So whatever the routes to that, whether it's Schwartz rounds, supervision, reflective practice, these are not solutions by themselves, but they are ways to disrupt. They're potentially ways to create better conditions, a chance to pause and process, potentially a learning space where we can share. I think another way to enable better conditions is normalising feedback. And Care Opinion is an organisation that's very much trying to normalise the idea of feedback. So we go back to what I was saying before about those tensions, you know, it's really important for getting feedback through an organisation around where might the balance not quite be right, so we can address that. But if we normalise feedback so that it's just a part of our normal way of doing things, it's, you know, if something more challenging comes along, we don't meet that with defensiveness because we're just used to having feedback. So if we can normalise feedback, it reduces defensiveness. I think we made the point, I went on and on about that actually, didn't I? Trying to raise consciousness is part of enabling conditions for growing relationships. And what I mean by that is acknowledging just how complicated all this is. If we're involved in tensions and balancing acts all the time, at an individual level, at an organisational level, how can we grow to become more of a self-conscious organisation of uncertainties and continuous balancing acts? How can we be more conscious of that? And I think this is a similar outcome, or it's an aspired outcome for psychological therapy. I think the kind of Daily Mail version of psychological therapy is it makes us happy, and that isn't often the case. Or, you know, therapy is about having everything sorted. Psychological therapy is about becoming more conscious so that we can make better decisions or make different decisions. How can we have more conscious organisations so we can make better decisions? What choices do we have? If we want more human connection, what are the enablers to that? Where's the incompatibility? What's hidden that could get in the way of what we're saying we want to do? Let's make the hidden more visible. The last thing I put here, I put this because I've worked in the NHS nearly 20 years, and I have learned so much by speaking to people for this. And it just made me think, you know, I thought I knew stuff about this, and until I spoke to people, I just learned loads. So I think there is this idea, I see it in South me, that this idea of, you know, a person comes into hospital, you're safe now. And it's like, well, where's that come from? And do we need a more realistic sense of talking about harm that can happen? A sense of risk mitigation, rather than this will never happen again. The idea of a risk as low as is reasonably practicable. I think there's something about different forms of justice. Is this out there in the kind of public domain to be aware of those three forms of justice I mentioned, and that there's a need to separate the need for what's needed for system learning and what people need to heal and rebuild and grow trust. An awareness of that idea of compounded harm, that feels a really important thing for us to be aware of, not just the harm of an event itself, but the compounded harm of processes afterwards that are really distressing and obstructive. And I think the last thing, what are we willing to pay for? So if we're aiming for the greatest safety to the greatest number, and we want to acknowledge that harm is a possibility, but in context we'll try and mitigate the harm to a level that's as low as reasonably practicable. Well, what level is that? How do we decide what level is that? And how can we just have honest conversations as a society around where do we set that level and what's the plan? How do we respond when citizens are harmed? Because we're saying harm is there in the reality of healthcare, rather than reacting case by case. What is the plan? How do we respond when citizens are harmed? So, closing comments. I wanted to resist the temptation to end with here's the action plan, here's the eureka, because I don't think there are silver bullets, and I think that is the very seductive way of thinking, that we end with a kind of 3-point action plan, and we're always seeking that silver bullet. I wondered what Adam would be saying today, would be writing about. He wrote about what does good care look like, and with great clarity, and it was longer, but he said, where staff have time for me, they're friendly and chatty and make me feel as if I matter. Adam has a real clarity. I think we need to talk more openly about harm and these tensions and trade-offs. I think in terms of a wish list, I think, of course, it's an obvious thing to say, to have contexts where relationships are more possible, where there's space for people to feel listened to and explore, for staff to feel supported. I mean, that's all obvious, but I think that would be on a wish list. I think clinical psychology's got something to offer. Quick plug for my profession. And I think the last thing, just to say, is this from Myron Rogers, which is the process we use to get to the future is the future we get. I love that. I love that as an idea. And I think rather than trying to end with this kind of crescendo of silver bullets, that's a fair metaphor, isn't it? I think it's about the process. It's about Zoe's warm invitation 9 months ago, whenever it was, about the context for today. Have you got everything you need? The warmth of that. It's about honouring Adam's memory. It's about engaging with those 20 odd people before. It's that process, that engagement, that listening and hearing different views. That's the thing to take away, I think. It's the process we use to get to the future is the future we get.